So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline-concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV. Let's take a look at diagnosis of HIV. These are the recommendations from the 2014 CDC guidelines. Since 2014, it's been recommended to use an assay that's a combination of antigen antibody, and these are antigen and antibodies from both HIV-1 and HIV-2. And if this does not test positive, so if it's non-reactive, now assuming that the patient has not had a risky behavior in the previous 15 to 20 days, then we can confidently conclude that the patient does not have HIV. And this test has a very high sensitivity and specificity. It does take some time for the body to make antibodies and for the antigen levels to increase in the plasma levels. Therefore, if someone has just been exposed to HIV, this test is unlikely to detect it. Now, if someone does test positive, we don't know if it's HIV-1 or HIV-2. So therefore, we need to do another assay, which is an antibody differentiation, to figure out if this is HIV-1, HIV-2, or both. If antibodies for HIV-1 are detected but not HIV-2, we can conclude that the patient has HIV-1. If the antibodies for HIV-1 are negative but HIV-2 is positive, we can conclude that the patient has HIV-2. If both of them are positive, then the patient actually is co-infected with HIV-1 and 2. And if neither of them test positive, now we have a problem, because initially the antigen antibody tested positive, but now we didn't find HIV-1 or 2. Now, to resolve this issue, we actually need to do nucleic acid test. A nucleic acid test is a lot more accurate because instead of antigen or antibody, it actually detects the HIV RNA. So if this tests positive, then we can conclude that the patient has HIV. And currently in the US, HIV-2 is not common. So the nucleic acid tests that are FDA approved are only for HIV-1. Now, if this patient does not test positive, we can conclude that the patient does not have HIV-1. And this is assuming that the patient did not have risky behavior in the past week. So it typically takes about 6 days for the RNA levels to go high enough for this test to actually detect it. This nucleic acid test is a qualitative test, so it basically tells you if the RNA is there or not. Regardless, when someone is tested positive, we actually need to do PCR in order to quantify the viral load. The primary reason that this algorithm exists is because these antigen antibody assays are actually more affordable than the nucleic acid test. So if you're using it for screening purposes, where majority of patients will actually be non-reactive, this is a more cost-effective way of screening people. And then people who test positive will actually end up with more tests and possibly nucleic acid tests, which are more expensive. Okay, let's take a look at HIV serology. So in this figure on the x-axis, we're looking at time in units of days after exposure to HIV. And you can see that the first few days, it's referred to as eclipse period. And it basically means that it takes a while for the HIV to replicate and actually become detectable. So what we basically use to detect HIV the soonest is the nucleic acid amplification test, which basically can detect it by day 6 to 8. whereas within the first 5 days, it's going to be undetectable. And then between days 13 and 20 is when the P24 antigen can be detected, and depending on what source you look at, you will see different numbers. So some sources say 15 to 20 days, some say 13 to 20. It's clear that around 2 to 3 weeks after exposure is when this antigen will be detected. And then it will take significantly longer for the body to make antibodies, and then those antibody tests to be detected. Now, up to 38% of new HIV infections are transmitted by people who are unaware of their HIV status. So it is important to screen people who are at risk for HIV. In fact, the 2019 USPSTF recommendations for HIV screening includes all adolescents and adults aged 15 to 65 years. And then people who are younger or older, if they have increased risk of infection, should also be screened. And of course, all pregnant persons, including those who present in labor or at delivery, whose HIV status is unknown, should be screened for HIV. So when should treatment be started in patients with HIV? Now, in the old days, it used to be that the recommendation was based on the CD4 count. So patients who had lower CD4 count, they were at higher risk of having opportunistic infections, cancer, and of course mortality. So and of course older HIV drugs were very toxic, so we would actually reserve it for more severe patients. But nowadays HIV drugs are very effective, they're very well tolerated, and we have clinical evidence that regardless of CD4 count, when we start treatment for HIV, we can actually reduce the rate of morbidity and the rate of mortality associated with HIV infection. And this mortality could be due to cardiovascular disease, it could be due to cancer, it could be due to opportunistic infection. So it actually can be significantly high. And HIV treatment can actually reduce these numbers significantly. And of course, the other issue is transmission, and we do have very good evidence that once we start treatment, HIV transmission will be significantly reduced. And this transmission could be to sexual partners, as well as vertical transmission from infected mothers to the infant. Now, the December 2019 update of the DHHS guidelines recommend initiating ART immediately. So immediately means basically the same day that the patient is diagnosed with HIV, or as soon as possible after HIV diagnosis. And this is because it has been shown to increase uptake of ART and linkage to care, as well as achieving viral suppression faster in individuals and improve the rate of virologic suppression in patients with HIV. Now, when it comes to ART, it is very important to educate patients about the benefits and considerations of ART and to address strategies to optimize adherence. So we will talk about adherence shortly, but adherence is very important. So if there is concern about patients achieving being adherent to ART, then instead of starting ART immediately, it may be more reasonable to delay it a little bit, but do it as soon as possible. So as soon as the patient has access to care and the patient is ready to adhere to ART. Interrupting ART can lead to rebound viremia, worsening of immune function, and increased morbidity and mortality. So therefore, once ART is initiated, it has to be continued with the following goals. So the goal is to maximally and durably suppress HIV RNA in the plasma, to restore and preserve the immune function in HIV patients, to reduce HIV-associated morbidity and prolong the duration and quality of survival, and prevent HIV transmission. Now, it is common that once ART is initiated, because these regimens are very effective, that the patient can actually achieve viral load reduction within the first 12 to 24 weeks of therapy. So within 12 to 24 weeks of initiating ART, the viral load should be undetectable. And recent data has shown that in patients who have a viral load of less than 200, so in general, less than 50 is considered undetectable. So even anything less than 200, studies have shown that the rate of transmission is basically non-existent. So Now we say the slogan U equals U, so undetectable equals untransmittable, and this has serious consequences when it comes to the stigma that's associated with HIV. So we're starting a new culture of U equals U, because as long as a patient is taking their ART and the viral load is undetectable, then they cannot transmit it to their partner. Now, generally there are three different strategies for ART regimens. The historic strategy would be the triple therapy, which basically would include 2 NRTIs or 2 nukes as the backbone plus a third agent. And the third agent can be either an integrase inhibitor or a protease inhibitor or a non-nuke. So 2 nukes plus a non-nuke. Now, in general, majority of integrase inhibitors are recommended first line, so that's why this one is green, and we'll talk more about specific agents shortly. We also have dual therapy. So dual therapy could be in 2 different ways. One is that you actually drop one of the NRTIs, and the reason we do combination therapy is that, you know, HIV has a high propensity for developing resistance, so by using combination we can basically prevent resistant development. So with the dual therapy, you basically drop one of the nukes, so you have 1 nuke plus an integrase inhibitor, which is, you know, first line. You also have 1 nuke plus protease inhibitor, which is alternative, and we'll talk about specific regimens shortly. You also have NRTI free or nuke free dual therapy. So this is basically no nuke included in the regimen. So this is basically a combination of integrase inhibitor plus a non-nuke, and the reason this is red is because it is not recommended as initial treatment. It's recommended for people who already have received treatment from another ART and achieved undetectable viral load, then they can switch to this strategy. Another non-nuke dual therapy includes integrase inhibitor plus protease inhibitor. Now, generally speaking, majority of first-line regimens that are recommended follow this rule that you need a backbone plus a third agent. So we use 2 nukes or 2 nucleotide reverse transcriptase inhibitors as a backbone plus a third agent. So it's important to have this combination in order to prevent HIV from developing resistance. And generally speaking, we have 3 backbones that are commonly used. So we have Epzicom, which is a combination of lamivudine and abacavir. We have Truvada, which is emtricitabine and tenofovir disoproxil fumarate. And we have Descovy, which is a combination of emtricitabine and tenofovir alafenamide. And I'll explain what's the difference between tenofovir disoproxil fumarate and tenofovir alafenamide shortly. Now, lamivudine and abacavir are 2 nukes that are commonly used in combination in Epzicom. So this will be 1 pill that would be used as a backbone. So if you are to use Epzicom as the backbone, you still need a third agent to go with it. Between lamivudine and abacavir, lamivudine also has activity against hepatitis B. Abacavir does not. So it's important to make sure that you are aware whether the patient also is co-infected with hepatitis B. Because, for example, if we are using something that covers hepatitis B and then later you decide to switch it to something that does not cover hepatitis B, the patient can have reactivation of Hep B and possibly Hep B flares, which could potentially be fatal. Now, all of these drugs in this class of NRTIs or nukes, because they actually are analogs of nucleic acids, that means that any RNA or DNA transcriptase can or polymerase can actually use this. So especially with the older NRTIs that we no longer use, they had an affinity for human mitochondrial DNA. Because of that, they were associated with lactic acidosis, and this became a black box warning, which for the entire class. So these new drugs that we use, or I should say relatively newer, compared to the drugs from the 80s, these have lower affinity for mitochondrial DNA, and therefore they are not likely to cause lactic acidosis. But regardless, the FDA has this black box warning for all NRTIs. One thing that's specific with Abacavir, before anybody can be started on Abacavir, we should actually do a genomic polymorphism test of HLA-B 5701, and you should only start Abacavir if someone tests negative for HLA-B 5701. And that's because people who test positive for HLA-B 5701 are at least they have a at least 50% increased risk of having fatal hypersensitivity reaction to this drug. So it's crucial to test this before starting Abacavir. So that becomes one of the limitations of using Abacavir, because you cannot. So if somebody tests HIV positive and you want to use this, you have to order this test, and it typically takes a few days, around a week, to come back. So it kind of delays therapy, but some patients may have no other option, so we have no choice but to test this, and then once they test negative, we can start a regimen that includes Abacavir. Now, all NRTIs are renally cleared except Abacavir. So Abacavir is actually cleared hepatically, so you may need to dose adjust it in patients with mild hepatic dysfunction, whereas all other NRTIs actually need to be renally adjusted. So, for example, lamivudine, creatine kinase cutoff is 50. Now, as a class, all NRTIs can cause nausea, vomiting, headache, rash, and increased liver enzymes. Lamivudine specifically is very well tolerated in general, but it does cause in some patients fatigue and insomnia. Abacavir, of course, can cause hypersensitivity reaction, especially if patients have HLA-B 5701. So HLA-B 5701 positivity is a contraindication, and of course it can also cause fatigue. Now, when it comes to the other combinations for the backbone, we have either Truvada or Descovy. So Truvada was their first, which is a combination of emtricitabine and tenofovir disoproxil fumarate. And these two combinations, both of them cover hepatitis B, and of course they still have this lactic acidosis black box warning, which all NRTIs do. And both of them are renally cleared, so creatine kinase cutoff of 50 for these two. TAF, or tenofovir alafenamide, is a newer formulation of tenofovir, which is actually creatine kinase cutoff is lower, so you can actually still use it in some patients with CKD. Generally speaking, these drugs are very well tolerated. Emtricitabine specifically can cause hyperpigmentation. TDF can cause nephrotoxicity and bone mineral loss, and this in fact is the reason that we actually came up with a new formulation of tenofovir alafenamide, which still does have nephrotoxicity and bone mineral loss, but it's significantly less compared to TDF, and I'll explain that more. Now, note that this tenofovir does not cause bone toxicity, in the sense that it does not cause bone marrow suppression. It just causes some bone mineral loss. So this is not the same as bone mineral suppression. This just increases the risk of osteoporosis. Now let's take a look at the difference between TDF and TAF. So tenofovir itself is the actual drug. Tenofovir is the actual drug that's an analog of a nucleotide, and that's what needs to go inside the target cell to block HIV replication. The problem is, when you orally take tenofovir, it's actually not absorbed. So this part is the GI tract, and when you take a pill of tenofovir, you would like it to be absorbed and go into the blood, and then the blood, in the circulation, HIV actually is inside the CD4 cell. So the target cell is the CD4 cell. That's where HIV replicates. You want this tenofovir to be absorbed into the blood, and then from the blood to go to the CD4 cell, and then find the HIV virus and block its replication. The problem is tenofovir is not absorbed. So we had to do something. We had to come up with some sort of salt formulations that increases absorption. And that's why we had TDF. So tenofovir disoproxil fumarate actually gets absorbed from the GI tract. So if you were to give 300 milligram, it gets absorbed. And then a tiny portion of what gets absorbed goes to the target cells, CD4. Okay, and that's how much we need in the CD4 in order to prevent replication of HIV. Now the problem is the majority of this tenofovir is staying in the plasma where we don't need it. And guess where it goes? It goes to the kidneys. It's gonna go to the kidneys and it's gonna cause nephrotoxicity. It's also gonna go to the bones and cause bone mineral loss, things that we do not like. So this has become a problem because patients need to be on these drugs for life, and over time this can build up, and patients will start to have CKD, or if they already have CKD, the CKD will progress. And as we all know, as we age, we also are all susceptible to bone mineral loss due to just aging, and this will actually accelerate it. So people who have HIV and are aging and are on TDF, they actually will lose more bone mineral. So we came up with TAF, which is a different salt form. So it actually absorbs. So when you take this orally in the GI tract, it gets absorbed. Now majority of this goes into the target cell, so you get the same amount in the CD4 where you actually need it, and then a tiny portion of it stays in the blood where it's gonna go to the kidneys and it's gonna go to the bones and it's gonna cause some toxicity. But because this is a significantly lower concentration in the blood than compared to TDF, it has significantly less nephrotoxicity and bone mineral loss, and therefore we're starting to use more and more TAF compared to TDF because the efficacy is the same, because you get the exact same amount in the CD4 cell, and that's exactly why you see a huge difference in the dose. So TDF you need 300 milligram, and TAF you need 25 milligram in most regimens, unless you have like a inhibitor where you would use a 10 milligram. So if you have cobicistat in the regimen, for example, you will see 10 milligram. So which regimen should be initiated in a person living with HIV who has not received treatment in the past? So for people without a history of using Bictegravir as HIV pre-exposure prophylaxis, which is essentially most patients who are diagnosed with HIV, DHHS guidelines recommend a second generation Bictegravir combined with a backbone of 2 nukes. So we have Bictegravir, which is a second generation integrase inhibitor combined with emtricitabine and tenofovir alafenamide, and this is available as a single tablet regimen, Bictegravir. We also have Dolutegravir based regimens. We can have a combination of Dolutegravir plus emtricitabine tenofovir, so either tenofovir alafenamide or disoproxil fumarate. This essentially means that you would need 2 tablets, either TBK, which is the Dolutegravir part, plus the backbone of Descovy, or TBK plus Truvada. So this will essentially have patients on two pills. We also can have Dolutegravir plus lamivudine tenofovir. So it's either TBK plus Simduo or TBK plus Temixis. We also have a combination of Dolutegravir plus a single nuke as a backbone. So this essentially has lamivudine as the only backbone, and this is available as a single tablet regimen, Dovato. These regimens are recommended first line because they are very effective, they have a high barrier to resistance, and they are well tolerated, and they have minimal drug interaction. So these are essentially work very effectively for most patients. Now, for people who have a history of using Bictegravir as HIV pre-exposure prophylaxis, so essentially Bictegravir is an integrase inhibitor, and patients were taking it to prevent getting HIV, and they got HIV anyway because they could potentially have integrase inhibitor resistance. For these patients, we do need the results of HIV resistant testing before we can start these first-line recommended regimens. In the meantime, if we are to start ART while we wait for the results of the resistant testing, it is recommended to use a boosted Darunavir regimen for these patients. So Darunavir can be boosted by either cobicistat and ritonavir. And what this means is that cobicistat is essentially a potent inhibitor of CYP enzyme. So by inhibiting metabolism of Darunavir, it boosts its levels. So does ritonavir. Ritonavir itself is actually an HIV protease inhibitor like Darunavir, but it's such a potent inhibitor of CYP enzymes that we use them at such a low doses that it's not likely to do anything to HIV, but it has significant boosting effect on Darunavir. Now, with Darunavir cobicistat, with the backbone of emtricitabine and tenofovir, it does come as a single tablet regimen, Simtuza, but also we can take multiple tablets. So Prescobix, which has Darunavir and cobicistat in it, with a backbone of either Descovy or Truvada. When it comes to ritonavir boosting, Darunavir and ritonavir are separate pills. So Prezista is Darunavir, Norvir is ritonavir, and then we can have backbones of 2 NUCs added to them. Now, one thing that I do want to mention as far as first-line recommendation with Dolutegravir and lamivudine, because it only has a single agent as the backbone, there are 3 things to consider. One is that because it only has one drug active against Hep B, people who have Hep B co-infections do need another regimen to be active against Hep B, because Hep B can develop resistance against this. In other words, people who have Hep B co-infection, when you have emtricitabine and tenofovir, so we have 2 drugs that are active against Hep B, those are fine. But when you drop one of the Hep B active agents, then you should have another agent on board to avoid Hep B resistance. The second thing to consider is that we have to make sure that the baseline HIV RNA is less than 500,000 for patients to take this. Otherwise, if the baseline RNA levels are more than 500, they cannot take this. They have to take something else to reduce the viral load before they qualify for this. And the third one is that only HIV, only for patients who had genotypic resistant testing performed to rule out resistance. Now, the third group of people to consider is, what if the results of the resistant testing comes back and the patient actually has an integrase inhibitor resistance. So for these patients, we have, as mentioned, boosted Darunavir regimens that we can consider. Now, this obviously comes with a lot of drug-drug interactions. So if drug-drug interactions are prohibiting the patient to be on these regimens, other options are doravirine-based regimens. So we have a single tablet regimen, Delstrigo, which has doravirine, lamivudine, and TDF in it. There's also, if someone doesn't want the TDF and TAF is preferred, then 2 tablets can be used. So doravirine plus Descovy as the backbone. And then also we have rilpivirine as a single agent. So Complera has TDF in it and Odefsey has TAF in it. But essentially, this is perhaps the last as a last resort here, because patients who take rilpivirine, we have to make sure that at baseline the RNA level is less than 100,000, and the CD4 count has to be at least 200 or higher in order for patients to take this. Otherwise, if the CD4 is less than 200, or if the viral load is more than 100,000, this is not going to be as effective. Now, obviously, some patients cannot tolerate tenofovir, so because of the bone toxicity and the renal toxicity. So, for example, if someone has osteoporosis, perhaps tenofovir is not the best agent for these patients, given that they need to be on this for a very long time, perhaps lifelong. and also patients who have nephrotoxicity. Because we have other agents that are not nephrotoxic, it's best to avoid tenofovir. So these are the tenofovir sparing regimens. So as mentioned previously, dolutegravir, lamivudine is actually first line for even for patients who don't have a need for avoiding tenofovir. That's a good regimen as long as the viral load is less than 500,000. Other available options are dolutegravir, abacavir, and lamivudine. So this essentially doesn't have tenofovir, but the two backbones includes abacavir. Now, in order to use abacavir, it is important for patients to have a test called HLA-B 5701 in order to safely start. So if the results of this test is not available, we cannot start abacavir. So anything that has abacavir cannot be started, because patients who have these HLA-B 5701, they're very likely to have a hypersensitivity reaction that can be fatal. So Triumec essentially is good for patients who should avoid tenofovir, but also have a viral load of greater than 500,000. So if they don't qualify for Dovato, then they can get Triumec. One last point about abacavir is that it is associated with increased risk of cardiovascular disease. So for patients that have either established cardiovascular disease or if they have multiple cardiovascular risk factors, it is recommended to consider avoiding abacavir-based regimens. Now here you can see the regimens that are no longer recommended as initial ART. So raltegravir and elvitegravir are both first generation integrase inhibitors, and because they have low barrier to resistance, they are no longer recommended. Raltegravir also has the problem of having high pill burden, so this is multiple pills. It is not available as a single tablet regimen. Elvitegravir cobicistat is available as a single pill, single tablet regimen, but unfortunately, because it's pharmacokinetically boosted, it has drug-drug interaction. So other drugs that are being given to the patient needs to be checked for interaction. So for that reason, it's complicated and it's no longer recommended as first line. Boosted atazanavir, because of its toxicity, specifically hyperbilirubinemia. In fact, some clinicians refer to atazanavir as bananavir because patients typically get a yellowish skin because of this liver toxicity. And because it's boosted, it has drug-drug interaction, so it's not recommended. Efavirenz not only has a low genetic barrier, but the toxicity includes the neuropsychiatric effects as well as suicidality. And it also has many drug-drug interactions. So it really is not recommended as a first line, and patients in general should not be on efavirenz-based regimens, since we have many other regimens that are effective and well tolerated. And as we discussed before, relpeverin has restrictions, so RNA levels need to be less than 100,000 at baseline, and CD4 needs to be greater than 200. And it needs to be taken with food in order to increase absorption. So for that reason, relpeverin is based regimens as far as 3 drug regimens is not recommended. Now, those were recommendations for initial therapy. Once somebody's started on regimens and the viral load is undetectable, there may be opportunities to optimize ART based on adverse effects, drug-drug and drug-food interactions, number of pills, whether the patient is getting pregnant, cost may be an issue, stigma, and for example, if it's an oral regimen that's visible to friends and colleagues, that could cause stigma issues for the patient. So may perhaps an injectable that's not visible to other people might be a strategy to overcome this, and many other things that we can factor. So in general, there are 3 things we can do to optimize. One is that once somebody's viral suppression is achieved, you can pretty much switch to any other thing that's first line, because they're being shown to be highly effective. But also, there are a couple of agents that I'd like to touch base on. One is Juluca, which has dolutegravir and relpeverin. So this is essentially an integrase inhibitor plus a non-nuke. And because it does not have a nuke, it essentially doesn't have any component that's renally clear. So when you have patients with renal dysfunction, this essentially becomes a pretty a reasonable option, as well as for anybody that needs to avoid toxicities of all the nuke agents in general. The other one, which is, and by the way, Juluca is an oral agent. And then we have an injectable option. So these are long-acting Bictegravir and Rilpivirine. So these are 2 injections, intramuscular injections that will be done at the clinic. And essentially there are two long-acting options. So one is like monthly options. We also have a longer acting that's injected every 2 months. So this helps for people who don't want to take a pill every day, and they essentially get the injection every 2 months. And in order to qualify for this, the patient must have had a viral suppression for at least 3 months, and there should be no history of resistance to Bictegravir or Rilpivirine. And because this has not been tested in pregnancy, it's important to make sure that the patient is not pregnant and is not planning to be pregnant. Now, because these are long-acting, there's always the risk that if somebody's going to have a hypersensitivity reaction, then this drug is in the system for 2 months. So if there is a concern for that, there is an oral option that's a short-acting. So this is essentially taken daily, just to make sure that the patient tolerates it. So if they're getting Bictegravir and Rilpivirine for the very first time, and you want to make sure that they're not allergic to it, Vocabria is an option before they switch to the long-acting, but it's optional, because what we have seen in the studies is that the large majority of patients tolerate this. Hypersensitivity, reactional allergies are extremely rare to these drugs.